Hello and welcome back to the deep dive. And I have to say, the vibe in here today is a little different.
A little tense.
A little tense, yeah. I've got this stack of textbooks here that is, well, it's literally blocking my view of the window.
I see that. Miller's, Stolting's, Yao,
Uh,
the classics. Brings back memories.
it's giving me that very specific knot in my stomach that, only shows up about a month before major exams.
Aye,
So we're shifting gears. This is full-on exam prep mode.
I like it.
We know so many of you listening are postgraduate students, MB anesthesiology residents, DNB candidates. Maybe you're sweating over the Gujarat University exams right now or the national board. So we're going to role play this.
Okay.
I am the student, eager, maybe a little panicked. I've read the books, but I need to put it all together. And you are the senior MD anesthesia faculty member.
I can feel the stress radiating off you from across the desk. But honestly, I love this format. It cuts right through the noise. In a Viva, or when you're staring at that blank sheet of paper for a short note, you don't need generalities. You need precision. You need structure.
Yeah.
And you really, really need to know what the examiner is looking for.
Exactly. And the topic today is, it's a beast. We're tackling complex regional pain syndrome, or CRPS, and the gate control theory of pain.
It's doubleheader.
It is. Because you can't really explain the pathology of CRPS without, mastering the physiology of the gate.
They're inextricably linked. Get a question on one, you have to reference the other. It's almost a rule.
So just to be clear, on our curriculum today, we're pulling from the gold standards, right? Miller's Anesthesia, 10th edition.
The Bible.
The Bible, Stolting's for the Pharmacology, Morgan and Mikhail for those clinical pearls, and Yao and Artuzio for the case management side of things.
And don't forget the anatomy. We've got BD Teresia and anatomy for anesthetists for the block techniques. You'll need those.
Okay, Professor, let's dive in. Section 1, Introduction. I'm in the exam hall. The question is, define pain and discuss chronic pain syndromes.
How do I start? How do I not sound generic?
You start with the official definition, the IASP International Association for the Study of Pain. You need to quote it or get very close.
Okay.
Pain is an unpleasant sensory and emotional experience associated with, or resembling that associated with, actual or potential tissue damage.
Sensory and emotional. That's a key part.
It is. It acknowledges the psychological component right from the start. But for the exam, the real money is in immediately distinguishing between acute and chronic pain.
Right. The classic line. Acute pain is a symptom. Chronic pain is a disease.
Precisely. You need to elaborate on that. Acute pain is physiologic. It's a warning system. It's supposed to be there.
It tells you to take your hand off the hot stove.
Exactly. It matches the intensity of the stimulus and, crucially, it resolves when the tissue heals. Chronic pain, on the other hand, is pathologic.
It's the alarm that keeps ringing after the fire is out. Perfect analogy. It persists beyond the normal tissue healing time, and you should give a time frame. The accepted cutoff is usually 3 months.
3 months. Okay.
And you must say it has no survival benefit. It is maladaptive. The pain itself has become the disease. And this is where you pivot to CRPS. It's the quintessential example of a chronic neuropathic pain syndrome.
So if I get a 2-mark question, just define CRPS. What's the killer sentence?
Okay, here it is. Complex regional pain syndrome is a chronic pain condition characterized by spontaneous or evoked pain that is disproportionate in time or degree to the usual course of any known trauma or other lesion.
Disproportionate, that's the word.
That is the word. If you write nothing else, write disproportionate. The examiner's eyes will light up. It shows you understand the core concept.
Got it. Okay, before we get into the clinical nightmare of CRPS, we have to do the physiology, the gate control theory. This is the exam core.
It is. And you have to start with the history. Give the names and the year.
Melzack and Wall, 1965.
Yes. You must know those names. Before 1965, the prevailing idea was something called the specificity theory.
That's Descartes, right? The bell rope idea.
Exactly. You pull a rope at the foot because you burn it, and a bell rings in the brain, which is the pain. It was seen as a direct one-to-one hardwired system.
Which would mean that the amount of tissue damage should always equal the amount of pain felt.
And we know clinically that's just not true. You see soldiers in battle with massive wounds who report feeling no pain at all.
And then you get a paper cut and it's excruciating for an hour.
Precisely. Melzack and Wall completely revolutionized our understanding because they introduced the concept of modulation.
Right. The signal can be changed.
Yes. They proposed that the spinal cord isn't just a passive telephone cable carrying a message. It's a dynamic processing center. It's like a mixing desk in a recording studio. It can turn the volume of the pain signal up or down before it even gets to the brain.
And that volume knob is the gate.
That's the gate. So for your examiner-oriented definition, you'd say something like, the gate control theory proposes that the transmission of nerve impulses from afferent fibers to spinal cord transmission cells is modulated by a gating mechanism located in the spinal dorsal horn.
Okay.
And you have to add, this mechanism is influenced by the relative activity of large diameter and small diameter fibers, and also by descending inhibition from the brain.
That's a comprehensive definition. Okay, let's get into the weeds now. Section 3, the mechanism. This is exam gold. If I'm drawing the diagram or explaining it in a Viva, I have to know the players. Who are the fibers?
So think of it as two opposing teams, both trying to influence the outcome at the dorsal horn.
Okay, 2 teams.
Team 1,
Yeah.
the small fibers. These are your neuceptors, your pain fibers. That's the A delta and the C fibers.
And delta and C.
Your A delta fibers are thinly myelinated. They're relatively fast. They carry that first pain, the sharp pricking, ouch, sensation.
Only the C fibers.
C fibers are unmyelinated. They're slow.
Yeah.
They carry the second pain, that dull, burning, aching, throbbing pain that lingers.
Okay, so A delta is sharp and fast, C is dull and slow. What's their role at the gate?
Crucially, when these small fibers are active, their overall effect is to open the gate. They want the pain signal to go through. Small fibers equal pain equals open gate.
Got it. So who's on team 2?
Team 2, the large fibers. This is primarily your A beta fibers. These are the big boys. Thick, heavily myelinated, super fast conducting.
And what do they carry? Not pain, right?
No, they carry what we call epicritic sensation. Touch, pressure, vibration, proprioception, the non-painful stuff. And their job, when they're active, is to close the gate.
So it's a constant battle. The small fibers trying to open the gate, the large fibers trying to close it.
Exactly. It's the balance of activity between these two fiber types that determines how much pain signal actually gets transmitted up to the brain.
Okay, and the arena for this battle, where does this all happen?
The substantia gelatinosa. You absolutely must memorize this term.
Substantia gelatinosa.
It corresponds to lamina 2, and to some extent lamina 3 of the dorsal horn of the spinal cord. Think of it as the central sorting office. This is where those primary afferent C fibers terminate and release their neurotransmitters.
Like substance P and glutamate.
Exactly. They dump them onto the second-order neuron, the one that's going to carry the signal up the spinothalamic tract to the brain.
Okay, I'm visualizing the wiring diagram for the exam. So we've got the projection neuron, the one sending the message up to the thalamus. And then there's this other neuron, the inhibitory interneuron. This little guy is the key, isn't he?
The inhibitory interneuron is the gatekeeper. It's the physical manifestation of the gate. So here's the mechanism you explained to the examiner.
Okay.
The large A beta fibers, your touch fibers, they send a branch that connects to this interneuron, and it stimulates it. It excites the interneuron.
And because it's an inhibitory interneuron?
Stimulating it is like stepping on the brake pedal. The interneuron releases inhibitory neurotransmitters like GABA or enkephalins onto the projection neuron. So the signal is dampened or blocked, the gate closes, touch blocks pain.
Touch turns on the brake. I like that.
Exactly. Now, conversely, the small A delta and C fibers, the pain fibers, they also connect to this interneuron, but they inhibit it. They have a negative effect on it.
They take the foot off the brake.
They cut the brake line. By silencing the inhibitor, they allow the pain signal to blast through to the projection neuron completely unhindered. They've effectively thrown the gate wide open.
That's really elegant. It's just a balance of forces. Large fibers push the door shut, small fibers kick it wide open.
Precisely. And there's one more layer you should mention for bonus points.
Yeah.
The descending control.
From the brain.
Yes. The brain isn't passive in this. It sends fibers down, mainly through the dorsolateral funiculus, that release serotonin and norepinephrine into the dorsal horn. And these neurotransmitters act to strengthen the power of that inhibitory interneuron.
So the brain can send a message down to say, hey, close that gate.
Correct. Which is the physiological basis for why antidepressants, especially TCAs and SNRIs, work so well for chronic pain.
Yeah.
They're boosting these descending inhibitory pathways.
Brilliant. Okay, let's move to section 4. Clinical implications. This is marked as very high yield. Examiners love to ask, so what? How does this apply to my patient?
And the absolute most common everyday example is the rubbing phenomenon. You bang your shin hard on a coffee table, it hurts. What's the very first thing you do? Instinctively.
You grab it, you rub it like crazy.
Yeah, you're not fixing the tissue damage. You're not healing the bruise. You are instinctively using gate control theory.
So the injury fired off my C fibers, opening the gate.
A huge barrage of them. The gate is wide open.
Yeah.
But by grabbing and rubbing the skin, you are massively recruiting your A beta fibers, the touch and pressure guys.
Right.
Those signals, being on faster fibers, race to the dorsal horn. They powerfully stimulate that inhibitory interneuron and effectively slam the gate shut on these slower C fiber signals that are still trickling in. You are literally outcompeting the pain signal with a touch signal.
It's just hardwired survival physiology. It's incredible.
It is. Now, how do we apply that medically?
10NS, transcutaneous electrical nerve stimulation.
10S is the medical application of rubbing your shin. That's all it is. You place electrodes on the skin. Over the painful area, you dial in the parameters. What's the key parameter?
The frequency, right. It's a high frequency.
High frequency, low intensity, usually around 80 to 100 hertz. Why that specific frequency?
Because that's what stimulates the A beta fibers without setting off the pain fibers, the A delta and C fibers.
Exactly. You're selectively activating the large fibers. You are flooding the dorsal horn with non-painful noise to close the gate. You're creating a busy signal so the pain call can't get through.
So things like massage, physiotherapy, even acupuncture to some extent, they're all playing on this same principle.
To a large extent, yes. Deep massage stimulates deep pressure receptors carried by A beta fibers. Physiotherapy involves movement, which stimulates proprioceptors, also carried by A beta fibers. It's all about increasing the close the gate signals to overwhelm the open the gate signals.
Okay, let's bring it into our world. Section 5, gate control and anesthesia, an exam favorite. How do we link this basic physiology to our daily job in the OR?
Let's start with what we do most, regional anesthesia. Let's say we're doing a brachial plexus block for hand surgery.
Hey.
We inject local anesthetic around the nerves. What's the mechanism of a local anesthetic?
It blocks voltage-gated sodium channels.
Right. So it stops nerve conduction, it stops the action potential from propagating. And it does this in all the fibers, A beta, A delta, and C.
It just silences everything.
Everything. So in the context of the gate theory, if the C fiber input from the hand never even reaches the spinal cord, the open gate signal is never sent. The gate isn't just closed, the doorbell has been disconnected from the wall.
Okay, that's straightforward. What about neuraxial analgesia, an epidural or a spinal?
This is a bit more subtle and elegant. When we put opioids, like fentanyl or morphine, into the epidural or intrathecal space, they diffuse a short distance. Where do they go?
Into the substantia gelatinosa.
Into the substantia gelatinosa. They find the mu opioid receptors, which are heavily concentrated on the presynaptic terminals of the C fibers.
So they act before the neurotransmitter is even released.
That's right. They bind to those receptors, which inhibits calcium influx into the nerve terminal. No calcium influx, no release of substance P and glutamate. We are chemically padlocking the gate at the molecular level. It's beautiful.
And what about something more advanced like spinal cord stimulation or SCS?
SCS is the ultimate gate control therapy. It's the most direct application of the theory. We place electrical leads in the epidural space, right over the dorsal columns of the spinal cord.
And the dorsal columns are just massive bundles of
large myelinated fibers, A beta fibers. They're axons ascending to the brain.
So you're directly stimulating the close the gate pathway?
Massively. It's like taking the rubbing phenomenon and putting it on steroids, right from the inside out. You're creating such a powerful A beta signal that it completely overwhelms and inhibits the C fiber transmission at the dorsal horn.
Okay, that really ties the physiology together with our interventions. I think that covers the gate.
Yeah.
Now, let's pivot to the pathology, the broken gate. Section 6. CRPS definition and classification. This is absolutely essential.
Absolutely. You will get a question on this.
We defined it earlier as disproportionate pain, but the classification, it's changed over the years, hasn't it?
It has. You must use the current IASP classification. There are two types.
Okay.
CRPS type 1. This was formerly known as reflex sympathetic dystrophy, or RSD.
Yeah.
The key feature of type I is that it occurs without a definable major nerve lesion.
So what causes it?
It usually follows a seemingly minor trauma, a sprain, a crush injury, even just having a cast on too tight. There's an injury, but not to a major, named nerve trunk.
Okay, so that's type I. What's type 2?
CRPS type 2. This was formerly known as Causalgia, and the defining feature here is that it occurs with a defined, distinct nerve injury, a gunshot wound that grazes the median nerve, for example.
Causalgia. That's Greek for burning pain, right?
It is. It was first described in soldiers during the American Civil War who had nerve injuries. So for the exam, you should mention RSD and Causalgia as the historical terms to show you know the history.
But stick to type I and type 2 for the main answer.
Correct. And it's important to note that clinically, they look and behave almost identically. The treatment is the same. The only difference is the known presence or absence of that initial major nerve injury.
Got it. Section 7, diagnostic criteria. This is tough because there's no blood test, no scan for CRPS. It's purely a clinical diagnosis.
It is, which is why you have to know the criteria inside and out. And the standard we use now are the Budapest criteria. This is very high yield.
Okay, lay them on me.
First, the prerequisite. The patient must have continuing pain, which is disproportionate to any inciting event. That's the entry ticket.
The core definition.
Right. Then they must have at least one symptom in 3 of the 4 following categories. And on examination, you must find at least one sign in 2 of the 4 categories.
Okay, so what are the 4 categories?
Category 1 is sensory. This is hyperalgesia, which is an increased response to a painful stimulus. Or, the big one, allodynia.
Allodynia, that's the hallmark, isn't it? Pain from something that shouldn't be painful.
Exactly. The touch of a bed sheet, a cool breeze on the skin, drop of water. That's allodynia, and is a huge red flag for neuropathic pain.
Okay, sensory is category 1. What's 2?
Category 2, vasomotor. This is about blood flow. So you're looking for temperature asymmetry. One limb is noticeably hotter or colder than the other, or skin color changes. The limb might be mottled, red, or have a bluish cyanotic appearance.
And category 3?
Category 3, sudomotor edema. Sudomotor relates to sweating. So you're looking for sweating changes, either increased sweating, hyperhidrosis, or decreased sweating, anhidrosis, again, asymmetrically, or just frank swelling edema.
And the last one, category 4.
Category 4, motor trophic. This includes motor dysfunction, like decreased range of motion, weakness, or a tremor. And trophic changes, these are changes to the tissues due to abnormal nerve supply. Things like altered hair or nail growth, thin, shiny skin.
So to summarize the criteria, disproportionate pain plus signs and symptoms across those 4 categories: sensory, vasomotor, sudomotor, and motor trophic.
Yes. And there's one final crucial point you must make.
The catch.
The catch. It is a diagnosis of exclusion. You must state, there is no other diagnosis that better explains the signs and symptoms. You have to rule out other causes first. A deep vein thrombosis, a cellulitis, a compartment syndrome. You have to think of those and exclude them.
That's a critical safety step. Okay, let's go deeper into the why. The pathophysiology, sections 8, 9, and 10, peripheral, central, and autonomic. Let's start peripherally. The arm still hurts 3 months after the wrist fracture has completely healed. Why?
So peripherally, it seems to start with an exaggerated inflammatory response, what we call neurogenic inflammation.
Neurogenic meaning it's driven by the nerves themselves.
Exactly. Normally, nerves carry signals to the brain, but here, the C fibrinoreceptors start acting backwards. They release inflammatory neuropeptides, substance P, CGRP, out into the tissues of the limb.
So the nerve is attacking the tissue it's supposed to be monitoring.
It's literally fanning the flames.
Yeah.
This causes vasodilation, which is the redness and warmth. It causes plasma to leak out of vessels, which is the swelling. And it creates what we call an inflammatory soup that directly sensitizes the nerve endings themselves. This is peripheral sensitization.
Yeah, that still feels localized. It doesn't explain why the pain can spread up the whole arm or why it lasts for years.
Correct. That's because the problem doesn't stay in the periphery. It moves upstream. It moves to the central nervous system, to the spinal cord. And this is the concept of central sensitization.
The glitch moves from the hardware to the software.
Perfect way to put it. Remember our friends in the dorsal horn, the wide dynamic range, or WDR neurons? They're the projection neurons. In CRPS, they undergo a process called wind-up. Because of the constant, relentless barrage of signals from the periphery, their NMDA receptors become hyperactive. The magnesium plug that normally blocks them gets kicked out, calcium floods into the cell, and the neuron becomes fundamentally pathologically hyperexcitable.
So it starts overreacting.
It starts firing at everything. A light touch signal coming in on an A-beta fiber, which should be no big deal, now causes that WDR neuron to fire like it's being hit with a hammer. That's the neurochemical basis of allodynia.
And this process can even spread to adjacent spinal levels.
It can. And it doesn't just stop at the spinal cord. The brain itself changes. This is cortical reorganization.
The brain map changes.
Yes. If you do functional MRI scans, you find that the representation of the painful limb in the somatosensory cortex, the part of the brain that creates the body map, it actually shrinks and becomes smudged and disorganized. The brain literally starts to lose its connection with the limb. It stops recognizing it as self. This might be why some patients neglect the limb or report feeling like it doesn't belong to them.
That's fascinating and terrifying. Okay, that's central. What about the third part? Section 10, autonomic dysfunction. This is the sympathetic part of reflex sympathetic dystrophy.
Right. So normally the sympathetic nervous system, your fight or flight system, and the sensory pain system are two completely separate highways.
They don't talk to each other.
In a healthy state, no. But in CRPS, you get this abnormal crossover. It's called sympathetic sensory coupling. The injured pain fibers in the periphery start to express alpha-adrenergic receptors on their surface.
Which are receptors for?
Adrenaline and noradrenaline, the chemicals of the sympathetic system.
Oh, I see where this is going.
So now, anytime you have a sympathetic discharge, you get stressed, you get anxious, you even just get cold, the circulating adrenaline directly stimulates the pain fibers.
So your own emotions, your own stress response physically hurts you.
Exactly. And this also explains the vasomotor instability. The sympathetic system controls blood vessel diameter. When it gets dysfunctional, you get that unpredictable switching between a hot red limb and a cold blue sweaty limb.
That makes so much sense. Okay, section 11. Let's tie it all together. The relationship between gait control theory and CRPS. How do we synthesize this for an answer?
You should frame CRPS as a catastrophic failure of the gait control mechanism. It is fundamentally a broken gait.
Okay.
Remember those crucial inhibitory interneurons in the substantia gelatinosa, the gatekeepers?
The ones that are supposed to apply the brake.
Yes. There's evidence that in chronic pain states, these neurons can actually die off a process called apoptosis due to the excitotoxicity from all the glutamate. Or they just become dysfunctional, or GABA release is impaired.
Oh.
So the brake pedal is gone.
The gate is permanently stuck open.
It's stuck open. And worse, because of central sensitization, even the signals that should close the gate, the beta touch signals, are now being misinterpreted by those hyperexcitable WDR neurons as pain. So touch, instead of relieving pain, now causes it.
The whole system is inverted.
Completely inverted. Which brings us to the clinical presentation in Section 12 and the stages in Section 13.
Walk me through the stages. I know they can overlap in real life, but for the exam, it's usually described as 3 distinct stages.
Correct. For the exam, you need to know the 3 classical stages.
The acute or traumatic stage. This is usually the first 1 to 3 months.
And what does that look like?
This is warm CRPS. The limb is typically warm, red, and swollen due to that neurogenic inflammation. The pain is severe, often described as burning. And weirdly, nails and hair might actually grow faster in this phase.
Okay, so warm, red, swollen, burning pain. That's stage 1. What's stage 2?
Stage 2, the dystrophic stage. This is roughly from 3 to 6 months. Here, the picture changes. The limb starts to turn cold and can become cyanotic or blue.
So it goes from warm to cold.
Yes. The skin becomes thin and shiny, what they call glossy skin. The muscles begin to waste away or atrophy, and the nails become brittle and cracked.
That sounds much worse. And stage 3?
Stage 3, the atrophic stage. This is usually beyond 6 months, and the changes are often irreversible. You have severe muscle atrophy, the joints can become frozen in place contractures, and you see severe bone demineralization on X-ray, a patchy osteoporosis.
So the hand can become basically a useless claw. What happens to the pain?
Interestingly, the pain might actually decrease in this stage, or it might burn itself out.
Yeah.
But the functional loss is catastrophic. This is cold CRPS at its end stage.
So the progression to remember is warm and red to cold and blue to withered and stiff.
That's a very good way to summarize it.
Okay, that's a bleak picture. Let's talk about how we fight it. Management. Section 14, general principles. Miller is very clear on this. The goal is not just pain reduction.
Absolutely not. You must state this in your answer. The primary goal of CRPS management is functional restoration. We are trying to get the limb moving again. Chasing a pain score of 0 is often unrealistic and counterproductive.
And how do we do that?
There is only one answer, a multidisciplinary approach. You need a team, an anesthesiologist or pain physician, a physical therapist, an occupational therapist, and a psychologist, all working together.
And early diagnosis is key.
It's everything. If you can diagnose and start aggressive treatment in stage 1, you have a good chance of reversing it, or at least halting its progression. If you wait until stage 3, the battle is largely lost.
All right, let's break down the treatment arms. Section 15, pharmacological management. The drug ladder.
It's not the standard WHO ladder for cancer pain. It's a different toolkit. We can break it down into classes.
Okay.
First, the first-line agents are the membrane stabilizers or neuropathic agents. These are your gabapentinoids, gabapentin and pregabalin.
How do they work?
They bind to the alpha-2 delta subunit of voltage-gated calcium channels, primarily on those presynaptic nerve terminals in the dorsal horn. This reduces the influx of calcium and therefore reduces the release of excitatory neurotransmitters like glutamate.
So it's turning down the volume at the synapse.
Exactly. The next class is the antidepressants, specifically the tricyclics like amitriptyline or the SNRIs like duloxetine,
Well, we already talked about this. They work by epinephrine.
boosting serotonin and norepinephrine in those descending inhibitory pathways. They're helping the brain close the gate from the top down.
What else is in the toolbox?
Bisphosphonates like alendronate or pamidronate. They can be surprisingly effective, especially for the bone pain and to help halt that demineralization process.
Okay. What about for severe refractory cases?
Then we bring out the bigger guns, NMDA receptor antagonists. The main one we use is ketamine.
Ketamine infusions.
Yes. A low-dose ketamine infusion over several hours or days can be incredibly effective. Its job is to directly target and reverse that wind-up phenomenon, to put that magnesium plug back in the NMDA receptor and reset the hyperexcitable dorsal horn neurons.
And what about steroids?
Corticosteroids, like a short course of oral prednisolone, can be very effective, but only in the acute inflammatory warm phase of CRPS. In stage 1, where you have that redness and swelling, they can really dampen the fire.
Okay. Drugs are one part. Section 16. Physical and psychological therapy.
This is non-negotiable. You can give all the drugs in the world, but if the limb isn't moving, the patient won't get better. Physical therapy is the cornerstone of treatment.
But the problem is it hurts to move.
And that's where we come in. That's our job as anesthesiologists. We provide enough analgesia, maybe with a nerve block, to create a window of opportunity for the physical therapist to do their work.
What kind of PT are we talking?
A key technique is desensitization. It's pure gate control theory in practice. You start by having the patient rub the sensitive area with something very soft, like a piece of silk. Then you progress to cotton wool, then a flannel, then a rough towel.
You're retraining the nervous system.
You are systematically bombarding the gate with a beta signals to teach the spinal cord and the brain that touch is safe again. Another technique is mirror box therapy to help with that cortical reorganization.
And the psychological support.
Absolutely essential. These patients develop depression, anxiety, and something called kinesiophobia, a literal fear of movement. You have to address the entire biopsychosocial model of pain. You can't just treat the nerve endings.
Okay. Now for our specialty, the anesthetist playground, section 17, interventional pain management. This is marked exam gold.
This is where we shine.
Let's start with the classic, sympathetic blocks. For the upper limb, that means a stellate ganglion block. This is a definite Viva question. Describe the anatomy and technique.
Okay, let's visualize it. The stellate ganglion is star-shaped, as the name implies. It's a fusion of the inferior cervical and the first thoracic sympathetic ganglia, and it sits just anterior to the neck of the first rib.
Got it. And the key surface landmark for the block?
The key landmark you must name is Chassenac's tubercle. This is the anterior tubercle of the transverse process of the C6 vertebra.
Now wait, why C6 if the ganglion is down at C7-T1?
Excellent question. That's a common point of confusion. We aim for C6 for safety. If you try to go in at C7, you are dangerously close to the dome of the pleura risk of pneumothorax, and the vertebral artery is right there.
So we aim high and let the drug spread down.
We aim high at C6, where there's a nice bony backstop, and we use volume, maybe 5 to 10 mils of local anesthetic, to let it track down along the fascial plane to the ganglion.
Describe the classic landmark technique for me.
Patient is supine, neck slightly extended. You find the cricoid cartilage, which is at the C6 level. You move your fingers laterally, retracting the sternocleidomastoid muscle and the entire carotid sheath laterally. You push down until you feel that prominent tubercle.
Chassis.
Right. Insert the needle perpendicular to the skin until you make gentle bone contact. This is key. Withdraw the needle 2 millimeters. This takes you out of the longus colli muscle. Aspirate carefully, then inject.
And for the exam, I should probably mention ultrasound.
You must. You should say, while the landmark technique is the classic approach, ultrasound guidance is now the standard of care. It allows us to visualize the carotid artery, the thyroid, the esophagus, and ensure the needle is in the correct fascial plane. It makes it much safer.
Okay, what are the signs of a successful block and what are the complications?
A sign of a successful block is a Horner syndrome. Ptosis, a droopy eyelid, meiosis, a constricted pupil, and anhidrosis, lack of sweating on that side of the face. This is expected. It's a side effect, not a complication.
Got it. Now, the bad stuff, the complications.
The list is long. 1. Recurrent laryngeal nerve palsy, causing hoarseness. 2. Phrenic nerve palsy, causing paralysis of half the diaphragm. This is why you never, ever do bilateral blocks.
Right.
3, intravascular injection, especially into the vertebral artery, which can cause immediate seizures. 4, a total spinal if your needle finds a dural cuff. And 5, pneumothorax if you're too lower angled incorrectly.
That's a scary list. And for the lower limb?
For lower limb CRPS, we do a lumbar sympathetic block, usually targeting the L2, L3, and L4 levels.
And if these blocks work?
If they work, it tells us the pain is, at least in part, sympathetically maintained pain, SMP. It's a diagnostic block as well as a therapeutic one. If they don't work, it's sympathetically independent pain, SIP. For refractory cases, or if the blocks only give temporary relief, we move to the gold standard.
Neuromodulation, spinal cord stimulation.
Correct. As we discussed, SCS uses the gate control theory to override the pain signals. It's the best option for severe refractory CRPS that has failed all other treatments.
Okay, let's broaden out. Sections 18 and 19, the role of the anesthesiologist in CRPS and regional anesthesia. Miller talks about us being coordinators in the perioperative surgical home. What does that mean if a CRPS patient needs, say, an appendectomy?
It means we have to be extremely proactive. A new surgery is a new trauma, and it can cause a massive flare-up of their CRPS. Our job is to prevent that. We use preemptive analgesia.
So block the pain before it even starts.
Yes. We would place an epidural or a regional block before the surgeon makes the first incision. We want to stop that entire nociceptive barrage from ever reaching the already sensitized spinal cord. We act as the guardians of the central nervous system.
So using regional anesthesia in this context is a way of aggressively keeping the gate closed during a period of intense stimulation.
Perfectly said. It prevents the central wind-up from getting even worse. It can be the difference between a smooth recovery and a month-long catastrophic pain flare.
Section 20, comparison tables. High yield for Viva questions. Let's do a rapid fire. CRPS I versus 2.
Type I. No identifiable major nerve injury, formerly RSD. Type 2. A clear, defined nerve injury is present, formerly Causalgia.
Acute versus chronic pain.
Acute. A physiologic symptom, a warning sign, protective. Chronic. A pathologic disease state, maladaptive, no benefit.
And a tougher one, gate control versus central sensitization.
Gate control theory is the description of the physiological mechanism of pain modulation that exists in everyone. Central sensitization is the pathological failure and hijacking of that mechanism, leading to a chronic pain state. One is normal, the other is disease.
Excellent. Okay, section 21, common exam questions and Viva traps. What's a common mistake students make?
Trap number 1, seeing the significant psychological overlay and saying the pain is psychological.
Instant fail.
Instant fail. You must use the term biopsychosocial. The depression and anxiety are a consequence of living with debilitating pain, not the cause of it.
What's another trap?
When describing a stellate ganglion block, forgetting to mention its dual purpose. It is both diagnostic, it helps differentiate SMP from SIP, and it is therapeutic. You have to mention both.
And with gate theory.
Explaining the theory in vague terms, you won't get marks for saying big fibers block small fibers. You have to name them. A beta, A delta, C fibers. You have to name the location. Substantia gelatinosa, lamina the second and 3. Precision is everything.
Section 22.
Yeah.
Diagrams. I have to draw the gate control theory diagram. How do I do it quickly and clearly?
Keep it schematic. Don't get fancy.
Yeah.
First, draw a large circle or oval to represent a cross-section of the dorsal horn.
Okay.
Draw your large fiber, the A beta, coming in from the side. Show a line from it going to the projection neuron and label it with a plus sign. Then show another branch going to the inhibitory interneuron, also with the plus sign.
So it excites both.
Yes. Then draw your small fiber, the C fiber, coming in. Show it going to the projection neuron with a plus sign, but the branch going to the interneuron gets a minus sign.
Because it inhibits the inhibitor.
Exactly. Finally, draw your interneuron connecting to the projection neuron with a big fat minus sign. Then you can add a simple key. Large fiber stimulates inhibitor, closes gate. Small fiber inhibits that inhibitor, opens gate. Simple, clean, full marks.
Perfect. We are just about at the hour mark, so let's do section 23, summary and conclusion. Professor, give us the high-yield recap, the final cram session for the student walking into the exam hall tomorrow morning.
All right, here are your absolute take-home points.
Gate control theory, Melzack and Wall, 1965. Pain is modulated in the substantia gelatinosa, which is lamina 2 and 3.
You've had it.
2. The mechanism. A beta large fibers stimulate inhibition, which closes the gate. C fibers, the small ones, inhibit the inhibition, which opens the gate.
A beta closes, C opens.
3. CRPS is defined by disproportionate pain. Type I was RSD, no nerve injury. Type 2 was Causalgia with nerve injury.
Disproportionate is the key word.
4. Diagnosis is clinical, using the Budapest criteria. Remember the 4 categories? Sensory, vasomotor, Sudomotor, trophic. And it's the diagnosis of exclusion.
Budapest criteria, check.
5. The pathophysiology is a triple hit. Peripheral sensitization from neurogenic inflammation, central sensitization from NMDA receptor windup, and sympathetic sensory coupling.
Peripheral, central, autonomic.
6. The role of the sympathetic system. SMP versus SIP, sympathetically maintained versus independent pain, determines if a sympathetic block like a stellate will actually work.
Right.
7. Treatment is multidisciplinary. Physical therapy is number 1. Our blocks are there to facilitate PT, and spinal cord stimulation is the gold standard for refractory cases.
PT is king.
And finally, 8. Our role as anesthesiologists is crucial, especially in prevention. Use regional and neuraxial techniques preemptively to prevent flare-ups and block central sensitization during surgery.
That is an amazing summary. I feel like my final exam answer can almost be, we aren't just mechanics fixing a broken wire. We are software engineers trying to reprogram a glitchy central operating system.
I would give you full marks for that. That shows true understanding.
To all our student listeners out there, whether you're in Ahmedabad, Delhi, Mumbai, or anywhere else, sweating over these exams, you've got this. You know the physiology, you know the anatomy, and now you know how to package it for the examiners.
Go in there with confidence. Best of luck. Go crush it.
See you on the next deep dive.